Welcome to the MedTech Insider, where we give you an inside look to all things med device. My name is Parker Snedden, and I will be your host today. Thanks for joining us. Well, today we have two distinguished guests that I'm excited to chat with you both about degenerative instability. Before we get to that, though, I want you guys to introduce yourselves. So Jason Montgomery here, PA, originally from Indianapolis area, is now traveling the country and teaching physicians, PAs, NPs, all about Minuteman, Liberty, Patriot. And then Mort Rabii, super excited to have you as the second time guest on the MedTech Insider, the first second-time guest on the MedTech Insider. Yeah.
Thank you for the opportunity.
Yeah. Mort's an NP. He is a consultant for our company. He does a lot of teaching at the society level. APP of the Year, congratulations, by Aspen this past summer. So done a lot of work for us for the company, and just appreciate your insight too. So both educators, and so we're really excited to have them on today. So Jason, if you could start by just giving just a brief career path. How did you end up at Spinal Simplicity? You were a PA before. Introduce yourself.
So I spent about 18 and a half years in the pain and spine world. And prior to that, it was emergency department. And I always loved the getting patients back to functioning, right? They all have little goals. If we do this procedure for you, if we write these meds, if we do these activities, what's your goal? What do you want to get back to? And unfortunately, with a lot of stuff over time, over that almost 20 years of time, there's a lot of short-term pain management. Was a lot of short-term management, right? We weren't doing anything to change the pathophysiology changes that we weren't doing anything to correct those pathophysiology changes, right? We were just managing their pain with a lot of great stuff. But towards the end of my career, I was working with pain practice in Indiana and got introduced to Spinal Simplicity. Actually, Mort was the person who trained us here in Spinal.
Oh, really?
Kansas City.
Yeah.
We flew in for a special VIP weekend. Me and my doc and another nurse practitioner.
Mort was there during that weekend. Oh,
He was the only presenter. I think Dr. Kloster came in for a little bit at the tail end there just to kind of give us the,
Yeah.
But it was, that's, Mort and I hit it off right away that way. I mean, he was as passionate about patient care as I was, passionate about patient outcomes as I was. So always loved, the technology made sense to me. There's a lot of stuff that was introduced in my career that never used because it didn't make sense. But Minuteman made sense. So started ordering a lot of patients, seeing the outcomes, loved the results. I still miss getting little hugs from little old ladies in the office. That
Sure.
come out that's the best thing ever.
Yeah.
So so decided I want to retire from clinical practice. Teaching was always my favorite part of the job. So I decided to try to find something that where I could still impact patients' lives, but to do so by teaching best patient selection. And we made a list of the companies that I wanted to work for. Spinal Simplicity was number one, and they just happened to call me. So
I love it. I love it. And so what do you do now for the education team?
I am a professional education manager, and I travel teaching docs how to do the procedure. But more importantly, I work a lot with Neil Doherty, and we teach high-impact patient selection, imaging review, that kind of stuff. So docs who have primarily already been through training, doing patients here and there, and then we go in and teach them best ways to select patients and what to look for and make instability easy for them, and identifying on imaging. And they turned out pretty well so far.
You've done such an excellent job of taking a term, even degenerative instability, or we're going to talk about today, and simplifying it down for the APPs out in the market. You made such an impact in our company.
Thank you.
Are you 2 years in, Jason?
Wow.
You're not even 2 years in?
It was May of last year.
No way.
Yeah.
That's crazy. It feels like you've always been here, man.
Yeah, thanks.
So thanks for being on the podcast today. And Mort, if you don't mind just giving a little background You work with obviously Dr. Dan Kloster here in Overland Park, very involved in the societies, do a lot of educating. You've been working with Minuteman for years now.
Yep.
So
About 5 years.
yeah. So just a little career background from you as well.
Yeah, so I've been a nurse practitioner for 6 years, all in interventional pain with Dr. Dan Kloster here, born and raised in Kansas area. Prior to being a nurse practitioner, I worked as a registered nurse in postoperative orthopedics. So a lot of we did complex spine, total joints, stuff like that. And so kind of echoing what Jason was saying is the big passion of not only, treating pain, but also restoring function, the ability for somebody to, walk down the hall, walk my daughter down the aisle for a wedding, stuff like that, those kind of stories that, they can actually take care of themselves better. And spine has always been interesting to me, the ability to kind of restore some of that functionality. But when I started getting on into the pain management side and really seeing, hey, with these modern treatments, things like Minuteman, things like Liberty, treating the degenerative process, preventing it from getting worse, improving those patients' symptoms without some of the drawbacks of a larger surgical procedure, it really made sense, and I've loved every minute of it.
Yeah, you made such an impact in the market. I've personally witnessed many of your talks on stages and in small groups, and
I'm sorry.
he's being humble, everybody. Mort is excellent at communicating and educating out in the market. So thank you for what you do for the space, both of you. So, all right, let's get into this term called degenerative instability. And I think part of the reason why I wanted to get you both on this podcast, what we've been talking about here at the beginning, even is you both do such a good job of taking this, what can maybe be like a scary term for someone who's never heard of this, right? Like, what is degenerative instability? And it's something that we've been talking about as a company for years. And Jason, that's a big part of your job is, as you mentioned, is educating APPs and physicians on what this is. So let's start there. Let's start with you, Jason. What is degenerative instability and why should APPs care about this?
Okay. So the degenerative cascade in the lumbar spine is something that starts at a very early age, progresses throughout your life, accelerated by things like injury, comorbidity. But it's a normal process, right? So it's uh, abnormal motion across the segment where your bones and joints are no longer protecting the neural elements.
That's exactly what it is,
Yeah.
right?
Yeah.
Yeah. I mean, so you've got the bony structures not protecting the neural elements any longer.
Yep.
Right. But I think that word, like the word instability,
Yeah.
right? If you just take that word, there's lots of definitions to it.
Yep.
Right. And so I love what you said, though, abnormal motion in that segment.
Yep. And the big thing is that what we try to focus on is that degenerative change. So that you have, connective tissue that's lost structural integrity that's supposed to hold the bones in a certain range of motion. And that connective tissue has degenerated to the point where it's no longer constraining those force or constraining that motion anymore. So that's what we focus on is the degenerative part. There's lots of types of instability. We're not looking for gross instability or this massive motion because of fracture, like pars fractures, things like that. We're looking for that degenerative instability.
Yep. And why an APP? Like if you're talking to an APP right now, why should they care about that?
That's a great question.
Why
It's
do
one of those
the
things
other
where,
treatments fail?
right.
Yeah.
It's one of those things where it's your bread and butter. If you're working in a pain clinic, it's your bread and butter. It's what you see every day walk into your clinic.
Mm.
If it's your, and when I say bread and butter, what I mean is your epidural and RFA patients. If you're doing epidurals and RFAs on both, or if you're treating with both of those on the same patient, that means they have degenerative changes or they have instability findings on their imaging. It doesn't mean they needed a Minuteman right away or they need a refusion right away. But when they're getting to the point where those conservative care are not giving them the relief they want, then it's time to start introducing more advanced care, which would be something like Minuteman, tissue sparing device.
So Mort, to you, kind of backing up that statement there from Jason, as you have a patient in your clinic who has an ESI and an RFA, how do they present? What does that look like?
So, I mean, somebody to be treated with both of those. Okay, so going back to what are we treating? Okay, with radiofrequency lesioning, we're treating, pain, or specifically we're treating the transmission of pain signals from degenerative facet joints. Okay, so that's axial back pain. That's pain that is worsened with spinal extension, rotation, stuff like that. So back pain coming in, worse with load bearing when I'm carrying something, leaning back, lifting anything. Then somebody that is being treated with epidurals. Primarily, you're looking at the stenosis complaints, so radicular pain down the legs, etc. So, combination of both of those things. It's very rare that we see, at least in my clinic, it's very rare that you see somebody coming in with just one or the other. It's typically a combination of both of these, and most of these patients are coming in with these load-bearing issues. Hey, I'm up, I'm on my feet. The longer I'm standing up, I start getting this pain down my legs. My back starts getting painful. I start getting fatigued. Some of them aren't even complaining about like a true pain. It's just like my back feels tight. It feels heavy. It's tired. I got to sit down. So that kind of story, that presentation really clues me in on, hey, look, the spine is no longer functioning the way it should be.
You're nodding your head, Jason. You
Yes.
agree with this?
Absolutely.
Yeah.
I mean, you think about if you're an AVP who sees new patients, right? The most common new patient complaint is low back pain with radiation in the lower extremity. Those patients, a lot of times, probably more than 50% of the times, will say their back pain is worse, but because they have radicular type of pain, insurance companies won't allow you to treat the back pain first with like medial branch blocks and RFA. They say you can't do medial branches if they have radicular pain, so you have to do an epidural first,
Yep.
then a medial branch block, RFA, right? So, a lot of the patients who come in the clinic have this setup. Again, not saying they all need to have fusion, but definitely worth a brochure.
Yeah, down the line, probably
Down the line.
could potentially
Yeah.
be a candidate if
It is an ongoing process, right?
Yeah.
That degeneration, unless it's untreated, that degenerative cascade will continue.
So we talk about, and Jason, back to you on this. We talk about forward flexion bringing relief to the patient. Why do they get relief when they lean forward like that? We're kind of still talking about clinical presentation
Yeah.
here. So
So we call that self-decompression, and that's because when they lean forward, they're actually opening up the neural frame and the area where the nerves are being pinched. So it opens up the neural frame and the lateral recesses. So it's giving those nerves room to breathe. When you're standing, so you have degenerative instability, one of the first things you see is angulation and rotation changes. So when the person stands, you have this pie-shaped disc space that causes loss of disc height posteriorly, which narrows the neural frame and causes pressure on the nerve roots. When they lean forward, your facet joints are your axis, and so when you lean forward, you're actually moving the bones away from the nerves, decompressing the irritation.
The angulation is almost like the constant up torque on a torque, right?
Yeah.
yeah, that's a good picture of that. So then, as we connect the dots to the clinical presentation here, more over to you. What does that look like in imaging? What are you looking for, either X-ray or MRI, and why is that important?
Yeah. So, I think you could go either way here as far as like, okay, what comes first? Do you get an X-ray first? Do you get an MRI first? Um, I think by the time a lot of patients end up in most pain clinics, they will have had MRIs of the lumbar spine,
Yeah.
which means in order to satisfy most insurance companies, they're going to have X-rays as well, because most times it's you do your PT for 6 weeks, then you try some NSAIDs, and oh, by the way, you get an X-ray, and then once you've proven that there's nothing broken, then you finally get your MRI. So I think you're really looking at a combination of both of those. So the um, bread and butter kind of way to identify the patient and correlate the symptoms to what you see on the imaging, which is how you should do it, not starting with the imaging. See the patient first, get the story, then look at the imaging.
I do.
I know, right? But you get that imaging, you look at that MRI, you look, okay, is there an obvious area where we do have some foraminal stenosis, some central canal stenosis, facet joint gapping that you'll see on the MRI fluid in the facet joints or CT scan? This would see air in that one. But anyway, that's kind of the beginning of it. Then correlating that with If they haven't already had flexion extension x-rays, that's something that we always get in our clinic, is to really look at that dynamic portion now. Because think back to this degenerative instability, this kind of functional instability. How many of our patients complain about pain when they're laying down on their back? Not a lot of them. And that's the position that you get an MRI in, right? So this is a position of comfort. Those nerves are already relatively decompressed. Getting a weight-bearing x-ray, standing, flexion extension, you can really see the full dynamic range of what's going on in those joints.
Is that something, in both of your experiences, is that something that's typical of practices normalizing ordering flexion extension, or is that something when you're out educating that you have to tell people about that? Like this is important, guys, that we have to get this done. Jason, to you first.
I'm actually having to teach a lot of practices that, not just the APPs, but the docs as well. And then teaching them how to read those images, what you're looking for, what changes you're looking for, what are the important changes you're looking for. And then also, what are the contraindications that you're looking for?
Mm-hmm. So in flexion extension, Mort laid out some of it, but for you, like, what are you looking for in flexion extension?
To make it really simple, I'm looking at the posterior disc space and the foramen. So they're complaining of radicular pain. And so when you're in a standing neutral position, you're going to have narrow foramen. When you're extension, that's going to get even more narrow. When you flex forward, you'll see an increase in foraminal volume. That's why patients report relief when they go into forward flexion, because you're actually opening that foraminal volume or neuroforamen. And so you're correlating with what the patient's telling you with what you're seeing on imaging. Again, we're not treating the imaging. There's lots of bad levels on the MRIs, but that they don't all get operated on. We're treating the ones that correlate with their pain and symptoms.
Yeah, absolutely. So we've got clinical presentation. You guys have outlined well how that should connect with imaging. And then we get to kind of this weird part where we have to think about getting it actually approved by a commercial payer. So we've talked about for a while stenosis, right? So how does, and Jason, back to you here, how does stenosis connected to degenerative instability? And then maybe after you answer that question, the step further, like, how do we present this in a note so that a payer goes, oh, I understand what you're talking about?
Okay, so first of all, when I just want to distinguish how stenosis presents and how instability presents. Okay, instability is posture and activity dependent. Stenosis. Okay, so let me say it again. Instability is posture and activity dependent stenosis. Right, true stenosis due to pathologic change, is constant. They've had enlargement of the facet joints, enlargement of the ligament flavum, and disc osteophyte formations, those kind of things. So that change is permanent, right? Unless something's done about it. And stenosis presents as pain that's independent of posture. So it doesn't matter if you're standing, walking. True stenosis pain is there. It can be there when you're laying flat. When the mower asked that question earlier, I thought he was trying to trip me up. How many times? Well, if that's a red flag for me, if I see somebody who has pain, leg pain when they're laying flat, when they're like their worst time of the day is when they're trying to sleep, that's a red flag for me. Right. So, those two things, that's the way the patient presents distinguishes whether or not they're instability versus stenosis. But there's also what have they responded to? And your original question was?
Yeah, just differentiating stenosis and instability.
Yep.
And then how do we paint the picture in a note?
In a note.
Yeah.
Okay. So unfortunately, especially with Medicare Advantage programs, Medicare says that you must have instability due to, and it lists a bunch of different things, X-ray images that show are due to chronic degenerative changes, right? That's where we fall in. There's other categories like iatrogenic instability, which is where a surgeon goes in and he's going to do a decompression, but the amount of tissue and bone that he removes makes the segment unstable. So then they have to fuse on top of that so they're not causing more harm, right? So where we fit in all those different categories is the chronic degenerative changes. So instability due to chronic degenerative change. So
Yeah, absolutely. And that's a different way of thinking, I think, that our providers are used to over the
Right.
years of looking just for stenosis, quote
Yep.
unquote,
Yep.
right? And
Well,
so,
kind of goes back to, sorry to jump in,
No,
but it kind of goes back to exactly what you were talking about earlier, even asking about, how often are people getting flexion extension x-rays on these patients. It is a different way of thinking. It is these kind of devices, these kind of procedures are ushering in a paradigm shift for certain pain management clinics where you're no longer looking so much as how are we treating the symptoms of pain, but we now have an ability to treat the structural elements. We have to start approaching it from a more surgical eye, from a more, carpentry eye, so to say, is okay, you get these flexion extension x-rays so we can see where are things moving, where is that instability. A lot of times the posture dependent stenosis correlates with those levels because, well, guess what? It's posture dependent because of that instability. So that's how you kind of connect that dot of the radicular symptoms, which is being caused by stenosis because of the instability. You start making that picture. So
So the way you would document it would be like I'm pick a level here. So it'd be degenerative instability at L4-5 uh I'm sorry, it'd be degenerative instability at L4-5 as evidenced on X-ray and MRI by facet joint or effusions in the facet joints, posterior disc bulge, angulation and rotation changes as seen on X-ray or dynamic imaging, causing neuroforaminal stenosis, making pain worse when they walk and stand, that kind of thing. So you have to tie the stenosis to the instability in order to get approval, unfortunately, because the Medicaid Advantage or Medicare Advantage programs will screen for that.
yeah, and we know, as you guys know, as clinicians, that the stenosis primarily is being caused by, like you just mentioned, with the instability, and so that's how you tie it together.
But they will deny, though, based on if they feel like instability is the primary pain generator, they're gonna deny for that, right? Let's say, "No, that patient needs, decompression rather than fusion," right?
so I
So
think you meant if they feel stenosis is the
Stenosis.
primary pain
stenosis,
generator.
yeah, if they
Yep.
feel stenosis is the primary pain generator, they will deny it and say that the patient needs a decompression plus or minus fusion,
Yep.
right? Um, if it's so you have to so if the patient you have to report what the patient's saying, they have pain with worse walking and standing, so that their presentation describes instability, but then you also have to refer to the radiographic imaging that supports that as well.
Yeah, you have to document what you see in the clinic and then what you all are seeing in imaging. But I think the key take-home message there is it's degenerative instability causing that stenosis, right? But really, it kind of goes back to what you guys were saying at the beginning in your career, where there wasn't anything, there weren't as many tools
Yep.
when you first started to help with something like this, so you weren't looking for it,
Right.
right? Has that been your experience, Mort? Yeah.
Absolutely. And we were always taught that instability meant gr man instability meant gross instability, massive motion that needed its fusion right away, right? What we're looking for is more of this angulation, rotation changes, pain that's not getting better with epidurals and RFAs. They're not getting the durable relief they want. Maybe even getting less relief than they have over previous periods, right? Um, we're not looking for gross instability, more than 3 or 4 millimeters of translation.
Right.
That's not us.
I think a good place to look for those patients as well is kind of like, those patients that, like you said, they're not getting the relief with the epidurals, the radio frequency. They're not getting as long-term relief. The patients have, maybe you've referred them on to see surgeon. The surgeon has looked at them and said, nope, you are not bad off enough that, to require surgery. I don't want to operate on you because, there's nothing bad there yet. Those patients come back to you and kind of like, okay, what am I going to try? This is probably where they fit in. We had a gal that was sent to us, from a local surgeon because of exactly that. She's got a little bit of stenosis here, a little bit of angulation at L4-5, pain mostly down the legs, and yeah, you should try a pain pump. That's, I think, going to be the big treatment for you because I don't see anything that's going to be great. They'd had stimulator before, which shockingly failed because it was mostly a mechanical situation. Luckily, the patient was amenable to try something else. I said, hey, let's look into this a little further, and time will tell long term, but we're about 6 weeks in. She's walking significantly better. She's got a lot less pain following the Minuteman, and she's so far pretty happy.
That's amazing.
That's great.
Knuckles on that one, man. I mean, what he just described there is really the premise of the Minuteman technology, right? These are the patients we're thinking about that were uh, benignly neglected, right? We talk about that. Not maybe intentional, but they're not surgical candidates. They had nowhere else to go. And in the past, where would they end up at? We talk
With pain management.
yeah,
Guys can now strike
Yeah.
opioids for a long time or do epidurals frequently, but they're not a surgical candidate. That term is questionable for me. So
uh-huh.
because what the doc is saying at that time, the risks don't outweigh the benefits.
Correct.
Right? This is a big open surgery.
Yep.
And that your pathology isn't where I think it should be in order to open you up and put these big rods and screws and interbody device in.
Yep.
That's different than surgery with Minuteman, which is usually 15 to 20 minutes of anesthesia and placement of a device that has a great fusion rate. Yep. That's another option too for those patients who aren't good surgical candidates because of comorbidities, lung disease, heart disease, tobacco use, diabetes, things that a lot of times anesthesiologists would say, I don't want to put them under for 3.5 hours.
Yeah, much less invasive option
Yes.
than the big open surgery. So certainly we would all acknowledge there's pathology that would require an open surgery.
Yeah,
The
there's
Minuteman absolutely
absolutely.
cannot help. And so,
Of course.
yeah. Okay, a little break here. We're going to have some fun. So I got a few
Yep.
questions for you to get to know both of y'all a little bit better. We'll start with you, Jason. So if you could trade places with any other role in the practice for one day, what would it be?
Man, I know it's a really close role, but Steve Saar
Yeah.
has to have the best, most fun. And,
Yeah.
he's in the lab all the time,
Yeah.
getting to be a part of all the different new devices coming out and, different VIP labs. I think that would be the best part.
Yeah. So Steve Starr works here at Spinal Simplicity in Kansas City. He's in our local lab all the time.
Yep.
He gets kind of that hybrid fun role of
Oh my gosh.
engineering and then the physicians that come in and test out products. So yeah.
Yeah.
Okay. What about you, Mort?
I was trying to figure out a good sarcastic answer for this.
Shocker.
Because, it's like, who would I want to change places with for a day? And, I think it would probably have to be like our authorization, like our prior authorization guru.
Okay.
Mostly just because, I occasionally need something to make me hate life even more. Than just staring at the endless abyss that is documentation and insurance prior authorization.
Yeah.
And I think that would work.
That would do it. That could help. All right. If you weren't an APP, what job would you have, Jason? I know you're a PA and you were that, and now you're here, but what else would you do?
I'd have to say professional bowling.
Okay. You've got to elaborate on that. Why professional bowling?
It's something I found that I could still compete in. When I was a younger guy, I competed in wrestling and mixed martial arts, and but now as I get older, had all the surgeries I've had, it's something I can still do, and still do really well.
And right before we started the podcast, you told a story about how when you started, you were in last place in your league, and then you went to 5th place, ended up winning it. And so this is something you're good at here.
Yeah, I'm a technique guy. Wrestling is a very technical sport. Technique typically wins over brute strength, and so it's something I learned at a very young age. You learn something to where you can repeat the pattern over and over and over again. And bowling was easy for me to do that.
Okay. Mort, how about you? If you weren't an APP, what would you do?
Let's see, if I was not doing this, I think what I really enjoyed, up and through college, I minored in music. I played cello. And, had a lot of fun being in the symphony, just playing music. Couldn't really do that to make a professional career, but, if money was not a thing, yep, I do that.
You still do that as a hobby?
With enough whiskey on board and especially around the kids.
Okay.
So I still have a cello. So
We got to see you play sometime, man. That would be fun.
holiday party, let's talk about it.
Okay. I'm in. I'm in. All right. If Jason, for you, if your coworkers gave you a clinical superlative, or we could say just that spinal simplicity, what would it be? Like most likely to save your pen, or most likely to speed chart, or most likely to do something out in the field? What would they? How would they describe you?
Most likely to uh, over, or so let's see, most likely to go overtime on a lecture.
Okay. So you're not going to be the one that's going to go short on the time or not? Is
I'm usually after
Mortisher? He's over here.
Yeah, yeah. I think I'm one of those guys. I think every little details matters, and because those details add up to paint the perfect picture of what your patient's experiencing and what you should do to help them. And so I go into a lot of the details.
Okay, so you see Neil and Allie giving you this all the time. Like,
Oh,
come on,
yeah, yeah.
shut it down, Jason. Shut it down.
Yeah.
That's awesome. How about you, Mort? How would you be described?
Definitely would not be most likely to save the pen. I'm losing those all the time.
Yeah.
Uh, s- um, Probably the guy that overthinks,
Okay, most likely to
a
overthink.
little over analytic.
Okay.
So
So most likely to bring the cello into the office.
yeah, it's never happened yet.
Okay.
Bring the kids to work day. That does
There you go.
happen sometimes, though. That's kind of fun.
All right, good stuff. Well, thanks for letting me ask some fun questions there to get to know you guys a little bit better. Okay, let's circle back to you here. Let's talk about just conservative care. And so, as we're thinking about degenerative instability, what does a patient need to receive in order to get to that spot where we might be thinking about Minuteman?
Yeah. So the conservative care, and this is kind of, we obviously all want to start with the simplest thing possible, the keep it simple, stupid, right? So you want to keep the thing simple. And part of my job is really finding out, okay, look, how many of these things, what have they done and tried prior to getting to my office? Because, for a lot of these patients, people see provider after provider. I mean, sometimes we get the patient that's the first time in dealing with a sciatica symptom or, instability. But a lot of times in pain clinics, okay, they've seen somebody down the street, they've done this, they've done that, the other thing. Number one, NSAID medication, so anti-inflammatories to deal with the arthritic changes, or looking into, okay, is there a reason why they can't? Kidney disease, anticoagulation, previous GI surgery, etc. And then looking into, have you done physical therapy? If so, how long did it help? Some insurance companies really want to drill that down and say, okay, look, the patient's been having, painful symptoms and issues for 10 years, but I don't really care about that. I want to know what they've done in the last 6 months. And then they get it really specific. But physical therapy, activity modifications, chiropractic care, what kind of physical activity that they're doing, and then, of course, the epidurals, the RFAs, and MBBs.
Okay, very good. Jason, over to you. So we talked a little bit ago about you did the degenerative cascade. So we're talking about degenerative instability here. But as that disc gets smaller over time and that cascade happens in that segment, how could Minuteman potentially help and prevent that pathology getting worse in that segment?
It's a great question. Um, you're addressing so that the cascade uh, will progress at a very predictable through predictable steps. One step leads to the next step leads to the next step. Along the way, it produces predictable symptoms at each step, right? And so our goal is to be able to stop that progression at that segment so that they don't get to a point where they do need a big open decompression, because we know that, looking at reoperation rates at 2 years, people who have just single level decompressions will progress to um, uh, secondary surgery within 2 years. And so we don't want to have multiple surgeries. So what we're able to do is able to go in, open up the neural frame, and by giving a good lift, uh, by putting Minuteman in between the spice processes, then we realign the or we balance the end plates, realign if there's any kind of spondylolisthesis. And there's people always think that when you're looking at spondylolisthesis, there's these big translations, right? And that's not really if you look at it. If you look at some recent papers, there's actually good information about these micro translations, 1 to 2 millimeters, that happen with flexion extension. That's a look at comparing the angle of rotation with the amount of translation that occurs, especially looking around the frame. But that's another topic. um, but we're able to realign those micro translations, balance the end plates, and then give them security with a long-lasting relief, by a durable relief, by causing that fusion to occur. So we've get them good results, but if our device eventually fails, that's not going to give them good results. So we actually give them a fusion or help them fuse so that they get long-lasting relief.
Yeah, well said. I think we talk about it as LBRS,
Yeah.
live,
Yep.
balance, realign, secure,
Yep.
to help potentially prevent that cascade at that level. So that's really well said. More over to you, just talking about maybe it's like some real world application in the clinic. As we have a patient that presents with radicular pain, claudication, they've failed conservative care. They come to see you. Maybe they've even seen a surgeon and had that consult. The surgeon says, as we mentioned earlier, not a candidate. What's next for an APP out there listening to this, and they come to you and that they present that way? Like, what would you do next?
Yeah, so really just kind of, dig in. Okay, they failed all the conservative care, stuff like that. So really take a moment after interviewing the patient, figuring out what their symptoms are. Okay, I've got leg pain. Do you have some back pain as well? Okay, why? What kind of physical exam findings? What kind of story? Why is this back pain causing? Is it worse when you're up and on your feet? You're bearing load. Now going back, connecting the dots to yourself, right? Looking at there's well published checklists as far as like identifying clinical instability, degenerative instability based on Punjabi and White's data. But really going back and saying, okay, they have leg pain. Why do they have leg pain? What's going on with the anterior column, the disc and stuff like that? Do they have a disc bulge, posterior disc height loss? Okay, that's resulting in, some foraminal stenosis. Okay, there you've checked off one box right there. Then looking at the posterior elements, okay, do they have some facet hypertrophy? Well, if they have axial back pain, the answer probably is yes. Okay, so then looking at that, oh, and there's a little bit of fluid in the facet joints there at that same level. Okay, there you've checked off a second box in that posterior column. And then finally looking at now connecting everything with those x-rays, because those first two sections you've really been looking at an MRI or CT scan, but now going back to the x-rays. Okay, do you have any spondylolisthesis? Do you have any angular instability, sagittal plane, issues, stuff like that? Connecting the dots there, you've got one in all three of these categories. Okay, by clinical definition, you have instability in the spine. This is what is leading to all these other symptoms. Here's what we can do to offer stability to kind of realign this, get in more of an anatomically functional or physiologically functional state to really improve, their pain and functionality. Then post that to the patient
You've done that a time or two.
once or twice.
Rolled off the tongue easily, man. Yeah. No, I mean,
I changed my answer. I won't be more.
yeah, right.
That means we have to work together.
I'm down.
Yeah. Okay.
That would be a good team.
Yeah.
Have you guys ever presented together before?
I don't think so.
We should make that happen. That would be fun. That would be fun. All right, let's wrap it up,
2
Jason.
hours later.
Yeah, right. Yeah, that's us in the back going, guys, come on now. Like, or it's 6 p.m. Like, I mean, everyone's fainting. We need to get them some food. Huh? No, that would be fun. We'll try to make that happen. Okay, so Jason, wrapping this up, we're going to look ahead here a little bit. So an APP that's listening to this podcast, maybe they work in a practice where a physician is currently doing Minuteman. but they don't have the full picture of what degenerative instability is. We were just talking about this upstairs in my office. I think you were in Utah. You were telling me a story about that. So what would be like one or two takeaways that you would give them, like starting tomorrow? What should they start doing tomorrow?
Um, First thing is realize it's more prevalent than you think it is, right? Just again, as pain management always thought instability meant gross instability, meaning needing surgery right away, having functional loss in their legs. You know, you know, but that's not what we're looking for, right? And then the next thing is start reviewing your own imaging. If that means looking at the radiology report, pulling up the image, and trying to correlate with what is on the report with what you see on the image, and start doing that. Because radiologists don't always have the time to call out all of the pathology that's there. So they may say, somebody who has angulation and rotation changes or angular instability, they may describe that as moderate degenerative changes with degenerative height loss, uh, mild foraminal stenosis, no instability, and no fracture identified.
Yep.
Right. So be able to verify those results on your own. Spend time with a radiologist if you can. I did that early in my career. I would go to the hospital and ask if I could hang out with the radiologist for a day, and they let me. And to be able to develop that skill. Be hungry, be a sponge, try to soak everything up.
Yeah, that's so good. Gentlemen, it's been awesome. I hope we painted a good picture for our audience today. You guys have done a great job of what is degenerative instability, how do they present clinically, patients do, reading and looking at your own imaging, and then just being able to take care of more patients. So thank you both. Appreciate it.
Thank you.
Yeah. Thanks for listening to the MedTech Insider. We will see you next time.